Um, okay, let me start. Hello, everyone. Welcome to University of Hawaii at Manoa's Center of South Asian Studies 39th Annual Spring Symposium focusing on health and community in South Asia. My name is Saloni Mahajan and I'll be moderating this session. I'm a PhD student here and I'm not going to waste my time talking about me. Please reach out to me if you have any questions or any technical difficulties. You can leave a message on chat and I'll try to help you in any way possible. Before we begin, I have a few housekeeping notes. Each presenter today will get a total of 20 minutes for their presentation, and I will give a 5-minute and a 1-minute warning in chat. Um, and we will have all presentations back to back, and we'll have a question answer session at the end of the session. Um, so for this panel on the power of data in public health and politics, let's please welcome our first presenter, Shreemoyee from the University of Florida, presenting the paper Behind the Numbers, Reporting Pediatric Cancer Cases in India.
Thank you, Saloni. I'll go ahead and share my screen and start then. Okay, let's see. Okay. Hopefully my screen is visible to all. Okay. So, hello everyone. Thank you for being here today. I'm Shreemoyee. I am a third-year PhD candidate in the Department of Anthropology at University of Florida. My paper is titled Behind the Numbers, Reporting Pediatric Cancer Cases in India. And in my talk, I will focus on how statistical data and reports on pediatric cancer patterns in India often overlooks the complex interplay between gender and social class, which leads to the disproportionate reporting of cancer cases. Recent data on pediatric cancer patterns in India suggests that there is a much higher ratio of boys in the age group of 0 to 14 years who are currently suffering from cancer when compared to girls within the same age group. Based on 1 month of fieldwork conducted in India's capital city of Delhi from June to July 2021, I explore in this talk how sociocultural factors such as gender and social class shape local beliefs and knowledge about cancer care, which directly contributes to the creation of a gender gap in pediatric cancer cases. I'll share some stories from my fieldwork which highlights the myriad of ways in which gender plays a significant role in shaping the narratives of pediatric cancer care in India, but which ultimately lie beyond the scope of statistical reporting. So my research setting is a 10-bed pediatric palliative care facility, which is currently the only biomedical center offering specialized palliative care services for children suffering from cancer in India. Recent discussions around palliative care as a human right has encouraged many hospitals in India to integrate palliative care programs to demonstrate better standards of care. To conduct this ethnographic research, I used methods of participant observation and semi-structured interviews to get a good sense of the daily practices of caregiving at the center. I interacted with medical professionals, children, and their families regarding their approaches to care as part of my broader dissertation project on children's experiences and engagement with palliative care practices. I observed daily interactions at the center, including how children communicate with their care providers, how healthcare providers administer care services, and how children and their family members express concern about these care services. During my fieldwork, a total of 7 patients were admitted at the center, 6 boys and 1 girl. On my first day, I asked Dr. Zara, the junior palliative care specialist, whether the ratio among male and female patients were usually unequal at the center. The doctor responded by saying, "Yes, we usually get more male patients. The only female patient we have right now is Ruhi." I was skeptical about whether her family would continue to avail our services here. The medical team has faced many challenges while dealing with her family. Ruhi is an 11-year-old patient suffering from an advanced stage of osteosarcoma and had to recently amputate her left leg. She was admitted to the center a month back when her leg had swollen to almost triple its size. She was in unbelievable pain and could barely walk or move. The doctors advised Ruhi's parents that she required immediate surgery, which was her only hope for any slight chance of cure. However, during the initial stages of her treatment, her father had vehemently opposed any sort of surgeries which would lead to a change in her daughter's physical body. Dr. Zara continued. It was really difficult for us to convince Ruhi's parents, especially her father. Dealing with her case made me realize how patriarchy is so deep rooted, even when it comes to one's health and life. When I returned to the center on the following day, I had a chance to speak with Ruhi's father alone. I asked him about his experience of admitting his daughter to the center and how he felt when he was told by the doctors that his daughter needed immediate surgery. He was eager to share his story with me and said, "We are not from this city. My family's understanding of Ruhi's illness is very different from the doctors here. I have not even told my extended family that my daughter is suffering from cancer. If I did, they wouldn't have even agreed to take her to a hospital. Due to this situation, my daughter's diagnosis was late as well, and it took us some time to travel to this city to get better treatment for her. All buses and trains were cancelled due to COVID, and it was difficult for us to travel so far with a sick child. I eventually found out that most of the pediatric patients and their families did not reside in the urban city of Delhi. Instead, they mostly traveled from the rural outskirts of the city where healthcare infrastructures are yet to see the light of development." Ruhi's father continued. "The first thing the doctors said after looking at my daughter is that she needs surgery and that they need to cut off her leg. I was horrified and I pleaded with the doctors that there must be another way. I refuse to believe that I'll have to see my daughter limp on one leg. How will I take her back home after this? My family will look down upon her. Who will marry her? How will she live out the rest of her life under shame and neglect? How will she deal with the daily taunts and teases? What will she do if someone takes advantage of her disability? I thought about not continuing her treatment here and look for other solutions, but there was no other way. The doctors had to do what they needed to do. They assured me that my daughter will be in better health and shape after this. I'm happy that my daughter is in less pain now, but I'm still afraid of how she will be treated in our village." I eventually learned that most family members of patients are hesitant about surgeries because they get concerned about how their children will be accepted in society with physical deformities post surgery. Moreover, hesitations around surgeries are particularly relevant for female pediatric cancer patients. In this case, Ruhi's father was concerned that no one would want to marry his daughter with one leg, which would further the societal stigma against his daughter and his family. Anthropological literature on how ideas of care intersect with local social ecologies has contributed significantly to challenging biomedical reductionism of caregiving practices. Ruhi's story points out how the social organization of families for people belonging to lower and middle income population groups in India continues to be mostly shaped by deep rooted patriarchal ideologies. Yet, these harsh realities of patients at the center remain invisible and unaccounted for within their palliative care plans. A recent report by the Indian Express titled "Girls Are Losing Out to Boys in the Fight Against Cancer" indicates that out of a total of 18,394 children from across India who were provided treatment for cancer, 65% were boys. The report further talks about how this gender gap is hampering pediatric cancer treatment among girls, as a result of which oncologists are calling for measures to address a range of issues from prejudice and awareness to even financial aid. Additionally, my conversations with the psychologists at the center conveyed several reasons behind the persistence of this gender gap within pediatric cancer care and palliative care treatments. Jasmine, the senior psychologist at the center, said, "I encounter treatment abandonment cases of girls almost on a daily basis. These poor girls often have several siblings and parents justify abandoning treatment by claiming that they are unable to uproot their entire livelihoods just for the sake of one of their daughters. Since they have more mouths to feed at home, they refuse to put all their focus and attention on a sick child, especially a sick daughter." During our conversation, the junior psychologist chimed in as well and added, "I see that parents of female pediatric cancer patients often get more concerned with the after effects of the treatment, such as chemotherapy and radiation therapy, rather than the disease itself. These treatments often result in hair loss issues and fertility issues, which is seen to undermine the femininity of a woman. Hence, they often choose to abandon treatments altogether or not opt for treatment in the first place and look for other options." These stories clearly reflect how care practices are embedded within larger sociopolitical dynamics of a society. However, reports of pediatric cancer cases fail to engage with these lived experiences of care, and in this case, problematize the intricate relationship between gender, social class, and care, which contributes to the unequal distribution of pediatric cancer cases in India. If one looks solely at the number of cases, one can easily conclude that boys suffer more from cancer than girls. These reports often don't question the very nature of this number itself. They don't indicate what is happening behind the scenes. And I quote Carlo Cadeff here. Social science scholarship has shown how numbers can deceive. Numbers have the ability to reveal as well as conceal. Therein lies their magic. They appear as seemingly neutral bearers of truth. They offer a sense of mathematical precision, making things seem more certain than they actually are, and displacing attention away from the conditions under which they were produced. Abstracting from limitations on the conditions of their production and treating numbers as absolute is dangerous because it makes things comparable that are not comparable, because it suggests scientific knowledge where there is a lack of evidence, and because it creates the sense of a major threat obscuring the differential nature of risk. What using numbers this way fails to account for is the fact that not everyone is at risk in the same way. I'm not trying to undermine the importance of statistical reports and numerical medical data or in any way implying that these data sets are useless. However, they do need to be accompanied by a critical analysis which examines why the numbers on reports appears to be a certain way. What do these numbers imply? And how does one go about collecting and publishing such numbers? The stories I shared reveal that the intricate connection between gender and social class continue to dictate how care practices are approached in case of female pediatric cancer patients. They are further connected to larger discourses surrounding the disability of a body, particularly of a female body, and what it means to be a woman in India. During my conversations with the biomedical healthcare providers at the center, I have often witnessed them expressing acute frustrations with family members of female patients. These family members get designated as ignorant or uneducated, which also indicates how it usually becomes the personal responsibility of individuals to fight gender inequalities in such cases. The emphasis then shifts from the socio-political organization of the state to the individual responsibilities and biases which these government agendas in turn implicitly shape and create. I further argue that while reporting pediatric cancer cases, these local gender dynamics should be explored alongside the organization of care ethics in India. Parvati Raghuram argues that most theorizations of care ethics have implicitly conceptualized care as a universal practice by drawing on care as theorized in the global north. Moreover, the history of colonial medicine in India, which has been shaped by a nationalist discourse, has always advocated for modernization of health and hegemony of Western medical systems. In addition to an inherent acceptance of Western medical superiority, the dominance of Western science and progress further implied a continuation of the colonial legacy of subordination and subservience of Indian systems of medicine and knowledge. This continued emphasis on Western medical knowledge systems has also paved the way for the hegemony of Western ideals of care, where biomedical and clinical dimensions of care take precedence over all other forms and understandings of care. These ideals further dictate who is worthy of care, who should be responsible for giving it, and the context in which it is given. During one of my interviews with Dr. Patel, a pediatric oncologist of a government hospital in Delhi, he said, "I know that access to proper healthcare, especially when it comes to female pediatric cancer patients, is a major issue in this country. Alongside that, most health professionals, especially in the field of palliative care, usually receive their education and medical training from Western universities. They are taught different care protocols corresponding to a specific economic context, which is more suited for the global north. When they return to India for their medical practice, they implement the same care protocols they have learned in the West, which then ends up doing more harm than good for patients and their families. Even though they understand the complexity of gender in availing cancer care, they are often not trained enough to address these issues in a productive manner." My observations at the center also echo Dr. Patel's concerns. The healthcare providers at the center diligently do their rounds, take notes of the patient's symptoms, and provide information to family members regarding the course of care plans. However, as the stories reflect, both patients as well as providers deal with several hindrances to care. The root cause of these hindrances often gets portrayed as ignorance or non cooperation by patients' families, and thereby undermines the role of the larger political organization of a society, which shapes notions of gender, health, and care. Nation states and economic markets play a central role in distributing and regulating care in contemporary societies. Hence, it becomes important to question the actions of larger institutional structures and medical bureaucracies, which often fail to adhere to the needs of both patients as well as providers, leading to the unsuccessful integration of care plans. To conclude, my presentation has attempted to capture the stories and lived experiences of cancer patients, which do not get reflected in the numerical reports of pediatric cancer cases in India. Alongside the numbers, acknowledging and understanding these stories are important. Conducting in-depth ethnographic observations becomes essential to capture the conflicts that hide behind these numbers, but may easily get overlooked upon because of the universal and static nature of numbers. Furthermore, to successfully capture the essence of care in these situations and acknowledge different lived realities of suffering and care, it is also important to understand what it means to be a person, to be cared for, and to be respected within a specific social context. Thank you.
Thank you so much, Shreemoyee. And just a reminder, we'll have a Q&A session by the end of it after all the presentations. Now let's move on to our second presenters, Neeti, Aryal, Khanal, and Neera Adhikari from Tribhuvan University, Nepal, presenting the paper, multiple vulnerabilities, COVID-19 and women with visual impairment in Nepal.
Thank you very much. It's wonderful it's an honor and privilege to share to be part of this conference. Thank you for conference organizing team for your support. Neera and I have been working together on issues of women with disabilities since 2000, and we have collaborated together for activism and research. However, this is the first time we're presenting a paper together. It's an honor also to write this paper together with Neera, who is an inspiring figure in disability movement in Nepal. I would also like to thank my student Rista for support in designing the slide. In our paper, we'll be talking about multiple vulnerabilities experienced by women with visual impairment in Nepal during COVID-19 pandemic. In presentation, we share experiences of women with disability using the data and also talk about lived experiences of women with disability. So me and Neera will be covering different sections together. In Nepal, when COVID-19 started spiking up, government suddenly instituted a nationwide lockdown with a very, very short notice in between the time frame March to July 2020. So domestic violence emerged as a shadow pandemic. In Nepal, Women's Commission runs a hotline in which people can call and register their complaint. So when comparing the number of complaints received during the same time frame before the lockdown and after the lockdown, we could see that the number of domestic violence complaints has increased twice. So that shows that during the COVID-19, domestic violence emerged as a shadow pandemic. So women also experience various forms of violence even within the government facility for quarantine. During the COVID-19 in Nepal and everywhere in the world, women also experience high level of emotional and physical care burden. Women were not only working on first shift, second shift, third shift, but also fourth shift, taking care of sick and elderly and also children who were at home as their schools were closed. So I would like to talk very briefly about women with disability in Nepal in general. Looking at situation of disability in Nepal, the very much fatalistic and superstitious belief on disability is very much predominant, and there's high level of shame and stigma associated with disability and families of persons with disability. And women with disabilities are considered as asexual and are denied rights of sexuality and reproductive health rights. So women with disability are also at very high risk of various forms of violence. And these evidences, me and Neera have worked together in range of different research together in the past. So talking about official data, the recorded number of persons with disability shows very low in census of Nepal, but according to the WHO estimate, it says that especially in a low income countries like Nepal, there should be nearly 15% of total population could be disabled. So we argue that these inconsistencies in the official data can be attributed to stigma and superstitions attached to disability, as family members still tend to hide women with disabilities. Talking about women with disabilities in Nepal, they are one of the most marginalized and vulnerable group. And in initial years, both disability movement and women's rights movement ignored the issues of women with disability. They were largely excluded also from development interventions and programs. But now Nepal has a very strong and thriving movement led by women with disabilities through a range of different organizations led by the women with disability, as you can see in the pictures. So this has now shifted the discourse by making women with disability more visible in the in Nepal. Over to you, Neera. I will still continue the slide sharing. You can start speaking. Neera, are you there? Hello, Neera. You can start speaking your section.
I think she's unmute, but she'll have to change her audio settings. There's a small arrow next to settings where you can change it to your earphone, like your headphones or the laptop.
Hearing now?
Yeah, we can hear you now. Go ahead, Neera.
Okay. Thank you, Neeti. Sorry for the technical problem. I'm going to talk about person with disability and disaster. Most of the persons with disabilities are badly affected in the disaster. The infrastructure and assistive devices are not disability friendly. The policies related to disaster is not gender and disability sensitive. Now I'm talking about COVID-19 and person with disabilities in Nepal. We have experienced multiple interconnected challenges due to COVID-19. In education, when COVID-19 started, government shifted classes into online. The children with disability didn't have access on it. They didn't have a smart mobile phone or laptop. They have moved to parents' home in the villages. Their parents could not support them as well because the internet facilities are not available in remote areas of Nepal. Among those children with intellectual disabilities were affected badly. Economy, government does not have disaggregated data on the employment. Various research shows that 1% people with disabilities have access on employment. 2/3 are employed in informal sectors, but these sectors are badly damaged. They need to depend upon scholarship and the disability allowance or relief materials at that time. Social effect. Persons with disabilities felt difficult to connect with the family and get support from them. Most of the persons with disability are living in urban area away from their home for the study and livelihood, but our government suddenly announced the lockdown without prior notice. Due to that, they were stranded without support. Most of the house owners didn't allow to visit their friends and supporters in their room. We felt difficult to maintain social and physical distancing as well. I'm going to talk about disability allowance. That is the issue in that period. Nepal government has been providing disability allowances for two types of disability, for profound and severe disability. During lockdown, government decided to cut down the disability allowance, which is provided for the severe disability, along with the allowances providing to single women below 60 years. They stated this allowance has to increase their financial burden. In the meantime, organizations with disabilities could make pressure to the government. Within a couple of days, government revisited the decision. Another issue is about the person with disability did not have access on relief materials because they need to submit their permanent residence card for the local government to get relief. Again, the organization with disabilities gave pressure to the concerned ministries to change the decision. Finally, person with disability could able to have access on relief materials from their living places. Thank you. Over to Neeti.
Thank you. Thank you, Neera, so much. So we will be now talking about COVID-19 and persons with disability based on the data collected by various right-based organizations. They have conducted a range of different surveys. So this part I will be sharing very quickly because you can see in the slide as well. I will not be elaborating too much because we want to focus more on the stories that we will be presenting later. So this shows that the immediate need seems to be the food. So that shows that persons with disability experienced challenges to meet their basic needs during the COVID-19. So also talking about the level of accessibility, it clearly shows that the materials, awareness materials produced by different organizations and government were not accessible for persons with disability. And also the data collected by National Federation of Disabled Persons Nepal shows that nearly half of the persons with disability lost their previous source of income during the COVID-19. And also the immediate needs of persons with disability during lockdown seems to be food, seems to be on the top of the list, and after that, health and hygiene. And also regarding the information, this data shows quite interestingly that persons with disability could not benefit from the information provided by the government and the established media houses, but they relied mostly on the information shared by their family and friends. So similarly, the hygiene materials were not accessible for persons with disability. And regarding the type of complaints received by the organizations with disability, major challenge seems to be not having enough food. So that shows how severely vulnerable and marginalized persons with disability were during the COVID-19 lockdown. And data collected by National Disabled Women's Association showed that women with disability experience various forms of violence during COVID-19. So looking at the perpetrator, family and neighborhood seems to be the major perpetrator of the violence. So now I'll be sharing, me and Neera will be sharing the stories. So we'll be sharing the lived embodied experiences of women with visual impairment. For us, this is important because data is very, very important to talk about the problems and the challenges faced by the community. But sometimes if we just talk about data and not talk about the experiences and stories of the people, sometimes those stories get hidden within the data. So we want to talk about 3 different stories based on the experiences of challenges faced by women with disability during COVID-19. So I'll be talking about how the story of a couple. It's a story that talks about how women with disability were denied from basic reproductive health services. So as you can see in the story in the slide, so they were a young couple who were previously, before the lockdown, living in Kathmandu. They both had means of income. Husband used to work selling the incense, the dhoop. He used to make dhoop and sell. And then Maya was also working as an intern and a teacher. They already had a child. So before the lockdown, they had visited Rautahar, their home, but they were stranded there when government suddenly decided to have a lockdown without much notice. So they could not, leave their rented room in the Kathmandu. And back in Rohtahat, Rami's family, they did not have a very good relationship with their family, so they had to rent another room. So they had to continue paying rent to 2 different locations because they could not check out of the rented room from Kathmandu. So then Maya was already pregnant. So during the lockdown period, she started having heavy bleeding. So when she went to the government hospital, like the reproductive health rights of persons with disability and international, regulations say that women with disability need to be prioritized for the reproductive health services. So that didn't happen in this case. They were returned saying we don't have ICU bed. So now Ramesh takes her to another private hospital, and private hospital says, yes, we can treat you, but you need to pay money in advance. They didn't have enough money for that. So fortunately, Ramesh used his network, and then his friends supported. So finally, she was able to deliver a baby. Now the baby is healthy, but Maya since then has been experiencing various forms of reproductive health complications, for which she needs to visit Kathmandu frequently while they are based in Rohtak. So these stories shows that COVID-19 made the reproductive health challenges of women with disabilities more complex. Over to you, Neera, for next 2 stories. We can hear you.
Are you hearing? Hello?
Yes, Neera, go ahead. Yes.
Thank you, Neeti. I'm continue the second story. The second story is about losing livelihood. It is the story of Namita, who lost her regular job in massage center. Namita is a single mother having a son. She was abandoned by her husband during her pregnancy. Then she fulfilled her responsibility alone. Her massage center has been providing employment for 24 visually impaired men and women as full-time employees. She sometimes could able to earn more than 60,000 within a month. After lockdown in the country, she felt difficult to pay the food and rented room because the lockdown is very long in our country. She tried to find the same job in other massage center. When she went there asking for the job, they asked for the unethical work, a kind of prostitute behavior. Then she denied their offer and returned her room. She even compelled to ask for the support to the disability organization and friends for relief materials and fees for her sons. She is a well-educated woman. Now she wants to change her job for the security, even in the disaster. Still she is not returned to her job. The next story, this is a story about domestic violence. Sharmila is 25 years old, blind mother of a girl child. Her husband was also blind. He used to work in the restaurant as singer, but he used to visit home to meet her and his family time to time. When lockdown was started, he refused to come to the home. He would either avoid her phone calls and using abusive words. Till date, their marriage has not been registered. When Sharmila requested, he didn't support her. Without getting marriage certificate, she didn't able to get her daughter's birth certificate. That's why she was in trauma. Meanwhile, she came to blind woman co-worker from the same restaurant. She sought support of women organizations and police station also, and organization warnings. Her husband went to get married another girl. He blamed her and behaved as a street lady. After knowing all this, Sharmila was emotionally disturbed and she decided to leave that home, and now she is in the process of getting divorced and partition from him. Now we are in concluding session of our presentation. The lived experience of women with disability and disabilities have proven that they were most disadvantaged group during COVID-19. The challenges faced by them have long-term social, economic, and health impact. Our government should prioritize these needs through policy addresses, and also we need to introduce a package program for their rehabilitation. Thank you for Neeti and for all organizers to hearing us. I'm going to end the session. Thank you.
Thank you all.
Thank you so much, Neeti and Neera. If anybody have questions, please add them in the chat and they'll be able to answer them at the end after all the presentations. And now for our final presenters, I would like to invite Nandini Mazumder and Suchitra Dalvie from Asia Safe Abortion Partnership in India, presenting their paper, Data Through a Feminist Lens, Analyzing Data, a Safe Abortion Advocates.
Hi organizers for selecting our submission and for inviting us for this. And I think it's been really interesting for me because I've always hoped for a greater collaboration between academia and activism or advocates. So I think it's a very important space for us to be here and to hear from all of you on what you've presented. So without much ado, I'll just start with my presentation. So we are a safe abortion network. We work regionally, we work across Asia. We have members, Asia Safe Abortion Partnership has members in across 23 countries in Asia, but we also work globally with partners and collaborators across the world. So currently I'm based in India, but as I said, yeah, me and Dr. Dalvie, we sort of represent the network, and we are, yeah, we work regionally. And unfortunately, Dr. Dalvie couldn't be here today, but I'm here and very happy to be presenting this. So this first slide is, of course, it's a cartoon, and but it's somewhat, gives you what we want to present today, that what is data really, and what do numbers represent, of course, and who comes up with these numbers, how and what. So interestingly, just yesterday, I remember going somewhere and I saw about 5 crore people received a welfare scheme. So it was very interesting because it was like pretty accurate. All our numbers should come with that disclaimer about, because all of it can be very much debated. So what is data? When we think of data and in the kind of work that we do, so we are a feminist safe abortion rights network. And what we see that data is often thought about is in numbers, is, scales and statistics, not really stories, but glad that the last few presenters also talked about stories, and data is, of course, the stories, but often it gets lost in those big numbers and statistics. So another important question to ask then, if this is what data is, that all these things together, then what does it reveal, and what does it hide? So a lot of the times we just hear, this many people got services, then how many people actually did not get those services? So these are some questions that we get lost in those big numbers and big jargons. Are the numbers indicative of something, or do they overshadow the human cost of a situation? So just like the last presenter talked about COVID-19 and how it impacted disabled people. So we see oftentimes, how COVID-19 has impacted gender dynamics, safe abortion services access. And yet we also see that a lot of these stories, a lot of these voices get lost. So something definitely there to also think about. And if data is validated only through numbers, does a single story count? So like we are all coming up with 1 or 2 individual stories, but policies and programs are often based on the bigger numbers and the bigger scales and statistics. So does these 1 or 2 stories count? And does even one person's, losing out on accessing some services or some rights, is that a valid thing for big when it comes to big numbers and how we look at the situation? So if a single story or stories in general don't count, then what do these numbers represent? So again, it's a question mostly for our policymakers, that if they are looking at these big numbers for coming up with welfare schemes or coming up with solutions for a particular community or society, then how what is it exactly that they focus on, and what do these numbers really indicate if they don't indicate stories? So this is, of course, like a very, a proverb that really sums it up, that stories also, we only listen to those stories that comes from the powerful, from those in authority. So even all of us here today that we are speaking about these issues represent a certain power. So and how long till we go to that point where, stories that are even today that are continue to being not heard will be heard? So this proverb just says that until a lion learns how to write, every story will glorify the hunter. So I think it pretty much sums up even when we look at data and when we look at stories, which stories get heard and counted. So again, data and coming back to some of the nuances that gets missed out. Who is collecting our data and why? Which data is being collected and how? Was informed consent taken before the data collection process? So a lot of times you will see, accepting cookies, that kind of a thing popping up on your computer screens. Not many of us read through these disclaimers. Not many of us know what it means to downloading an app, what it means to opening a website. So today we kind of, we are living in a data world, a data obsessed world. and we don't know how we are, where we stand when it comes to this process of data collection and data sharing. Is the data confidential and secure? Are there any risks of breaching the data and possibility of misuse? What are the data protection mechanisms in place? The questions are extremely important as data represents a person and must see purpose to improve things for the individual and or the community that it represents. So again, we many of you here are from a sociology background, and so am I. So we looking back at what Michel Foucault talked about, the surveillance society. Today, we are living in a surveillance society 2.0, where we not only just surveil from birth, from our birth certificates, to the point where our death certificates are handed out to whoever is there to collect, but we are also living in a constant world where our own screens are watching us. So kind of a big brotherish world, but here we are. And this is what the data is doing to us. And a lot of us are not really mindful or not really aware. Data and looking at it through a rights-based and social justice lens. So again, as a feminist network, it's really important to think about these things because a lot of the issues that we talk about are still criminalized in many parts of the world. Someone before me talked about sex work and as being an unethical work, but as a feminist organization, we support all these marginalized movements, including sex work, including reproductive justice. So it's important to see then how this data is being collected and how the data is being used to target people. So then and the nuances of data that gets hidden. And who is it benefiting? And I know a lot of the conversations has happened over the last few years, especially with Facebook, with Cambridge Analytica, but still there is so much more, that needs to be talked about. And preventing data breaches, of course, which, in South Asia and in many parts of Asia and the developing part of the world, it is a big concern because we are if you know that we have one of the most grave surveillance mechanism, which is called the Aadhaar, which is the unique identification number. And all of us have our UIDs, in a central database. We do not know how that's being protected, how that's being not protected, how that's being misused. And we have something as personal as even our iris scans on that database. So it's become a bit of, the kind of world that we live in, again, harps me back to George Orwell's Big Brother world. Then ensuring safety from invasion of privacy and misuse of data. And of course, this is again something that when we do not know who's collecting the data, where it's being stored, we of course do not have any control of how it's being used, misused, and what kind of privacy breaches we might be facing. So what challenges do we look at? So this looked very interesting to me. We often heard data is the new oil. What does it mean? Is it good? Is it bad? Oil wasn't good for a lot of people. So what does this really mean? So the confusion and the lack of clarity around how data is being collected and used or misused is definitely something that worries us as human rights and feminist activists. How do we navigate what we don't fully understand is another worry that we have, because also technology is constantly evolving. And earlier it was just the computer, but now even our smartphones are tracking us constantly. So it's a big worry when we connect to public internets. We are on our email or on using even very, very personal stuff like the banking apps. We are giving out a lot of information, but we really don't think about it. We even while conversing, I'm just thinking in my head that, yeah, I do that too myself. So, what are we really preaching? Then surveillance. Data is, of course, used to surveil. Again, we are seeing this in many parts of the developing world, including India, where we see particularly the civil society is under attack. And there's a lot of the data that is being used or misused to target anyone who has a dissenting opinion or anybody who's coming out as, somebody who's being critical of current policies or current systems. And of course, we are seeing that the data is being misused against people. Censorship. So now this is of course, a very important thing for us as safe abortion rights advocates. We constantly face this. I unfortunately did not omit it, but I think my presentation will have the next slides that will show you a little bit more on censorship. Sorry, if I can just stop a bit. I think this is a wrong, this is another PPT that's opened. Just. Sorry about that. So yeah, so I was on the issue of challenges. So yeah, so then privacy in the South Asian context. So all of us are this monkey. So this is my favorite meme out there in the internet today, because I think it represents so many of these issues that I'm talking about today. And especially when it comes to the concept of privacy in the South Asian context, because culturally it's not understood. There is no personal space that is a concept in South Asia. So in a way that whenever the government talks about like, you know, but and culturally we accept it, that why do you need privacy? If you've not done anything wrong, then what is it that you're hiding? And so in a way that we're all guilty before proven otherwise. So again, this is of course, you know, a homage to Michel Foucault and his concept of what he took from Jeremy Bentham's idea of the panopticon, and that we live in a surveillance society, which we do. So it's the panopticon is no longer just the physical prison, it's also right here and with all of us constantly. So as advocates for safe abortion rights and other human rights issues, we have to be seen and heard while knowing that online activities are being monitored and may be risky for us. So please remember, I also represent parts of the world like Indonesia, Philippines, of course, India as well, which is very, very, you know, right now in a very fraught situation, given dissenting opinions are constantly being branded as anti-national activities, but also parts of the world where even talking about feminist issues, talking about abortion rights can land you in prison. So and that's the you know, people that and that's the community network and people that we work with. And so this is what the risk really is for us when it comes to data and who's surveilling us, who's watching us, who's collecting the data. The second point is Michel Foucault. I've already mentioned it, so I won't go over it. Of course, the last point is that in the context of SRHR, where safe abortion rights are still being stigmatized and criminalized, data becomes highly contentious and you know, dangerous to talk about. This is something that from I would like to share. It's from, so if all of you can, you know, now that we've known each other, we've met each other, please do come and join us on our social media platforms. This is, you know, the catch-22. We have to be out there. We have to use all these pathways, but we also know the dangers there. So this is, of course, a catch-22. We do not know how to navigate. But yeah, we are there on Facebook. We are there on Twitter. We are there on Instagram. You will find us everywhere. And we do post a lot, and we do boost a lot of our posts, because unfortunately, fortunately, this is the world that we live in. So yeah, like activism is of course a risk. If you go out in the streets, you can be charged. And today the street is no longer just a physical space, but it's also online space. So we sort of look at it as a continuum. And this particular example that I'm presenting here is where one of the posts that we did was a play that, you know, one of our partners and collaborated with us and came up with. They've really worked hard. They've spent a whole year on coming up with a play on safe abortion rights. And we took out a bit of, you know, content from there, made a little trailer, posted it on our Facebook page and boosted it. So when we boosted it, it was, this is the message we get, that this cannot be run because this is causing, you know, this can cause disturbance because this is talking about a sensitive issue. Whereas you will go on Facebook and you will see n number of extreme right-wing pages. You will see extreme hate pages. So who decides what? The community standards. And therefore, if someone's deciding those community standards is collecting the data, is going to use or misuse the data, then that is a definite cause of worry for all of us. So visible and invisible data and its impact. So a lot of the data, as I'm saying, gets not only just collected, but also gets hidden. For example, safe abortion access. There is still, like, by and large across the world, you will see the umbrella term of maternal mortality. You will not come and, you will not see a lot of talk about or content or issues about specific to abortion, because abortion itself is not being recognized in many parts of the world. So due to the stigma and criminalization around abortion, data on unsafe abortion is missing. For example, in India, there's no official data on the proportion of maternal mortality caused by unsafe abortion. So as I said, and maternal mortality is like the big umbrella term, and this is probably the case for the rest of the world as well. Lack of data on safe abortion ensures that the issue remains hidden and makes it difficult for everyone. So of course, what we do not know, and we cannot talk about it. So safe abortion rights and is sort of in that bracket right now. There is no data on unsafe abortion. So how do we even advocate strongly around this as an issue? So the lack of data makes it easier for those in authority and policymakers to push it off as a non-priority. And of course, so yeah, big numbers are needed for policies and programs, and the policies and programs will not run on just on stories, because it's just easier to say, but there are 500 people who need food. Why do I allocate this much fund for 500 people who might die of unsafe abortions? So it becomes a very difficult conversation to have when we don't have the numbers, and stories are also very difficult to get, by the way. So, and of course, this is a woman who's, just wondering how the data is going to, be used against her, because if our data is being collected, will it be further sent to our employers? Will it affect our housing? Will it affect other welfare schemes? And we've seen that this has happened in many parts of the world, because you've seen in the US and all, there are parts of the US where you can't even access contraceptives without getting maybe fired from your job. So data as a weapon against safe abortion rights advocates, service providers, and service seekers. So yeah, as a safe abortion rights advocate, it's just very important for us to, again, look at how data can be misused against us. If the data is collected for the wrong reasons and by those in power to punish abortion seekers and service providers, then the consequences are fraught with dangers. For example, regular raids in abortion clinics, including online. So even online services are targeted, and in many countries, we still have, we are post-colonial countries. So we continue with the legacy of a lot of the laws that were left behind by the British rulers. And if you, so for example, IPC, which still criminalizes miscarriages, induced miscarriages. So technically, they could be used against abortion services as well. So in many countries, and we have examples from Philippines where partners had to, because they were getting raided, they had to literally chew on the SIM card, and mobile SIM card, and just to, prevent themselves from getting arrested. But in Indonesia, in the first lockdown itself, we've had a doctor who was arrested, a medical service provider who was arrested, and he died while in custody due to COVID-19 related reasons. So this is a constant, challenge for us. And how do we navigate that? Similarly, those who run helplines in restrictive environments are also constantly being worried of getting tracked by those in authority. Of course, also those in authority and those not in authority often collude. So I must give this disclaimer. And this is, again, a case study we've had from Pakistan, where there was a hotline that was being run by Asia Safe Abortion Partnership in partnership with other organizations like Women on Web and, so on and so forth. And it was very, very difficult. And the hotline was actually picked up by both those in power and from the right-wing fringes of the country. And, there was a lot of security issues. And so it was very difficult, and it's still a very challenge for us to see how hotlines are being maintained, who gets this, the caller data, how to maintain the caller data with confidentiality. We do not have those mechanisms and neither the resources. These are, yeah.
I'm so sorry, Nandini, but we are getting over time if you want to wrap up.
Sorry, yeah, I'm just at the end.
Okay.
Almost done. So this is, of course, the news article from Pakistan on the hotline all those years ago. And this is more recent and from Philippines and on the online abortion services. This is, of course, Aadhaar, because how can I talk about, health and rights and not talk about, and data and not talk about the Aadhaar. This is, of course, becoming extremely infringing on human rights in our part of the world and tracking all of us. And we do not know like really how. And therefore, what is the need for us at the current moment? So I'm just going back to talk about a little bit about one of the abortion drugs, in fact, was, discovered by women in Brazil, where and it's called misoprostol, and misoprostol was sold as a ulcer treatment drug. And women in Brazil discovered that it was actually an efficient abortifacient and started using it. And maternal mortality rates went down. And that's when researchers looked at that and studied it. And so we have to just remember that people are enough to know what they need to, and therefore we have to trust people with information, with data, and we have to finally, find a way to connect data back with people and humanize data. So this is it from my side. Thank you so much.